Hello, my name is Evan Yu. I'm a medical oncologist specializing in general urinary malignancies. I'm based out of the University of Washington and Fred Hutch Cancer Research Center in Seattle, Washington, where I'm a professor of medicine and oncology. And I'm here in Las Vegas at the 2022 ASCO Direct meeting. As a general urinary medical oncologist, today I talked about updates from ASCO and more recent meetings on prostate cancer. Specifically, there are really three areas that I focused on. The first area was on metastatic hormone-sensitive prostate cancer, as there is new data for triple combination therapy for treatment intensification for these patients. There is an overall survival benefit when you add to androgen deprivation therapy and docetaxel with abiraterone from the PEACE-1 study and with darolutamide from the ARASENS study. Generally, these patients were fit for docetaxel and had de novo metastatic prostate cancer. We have yet to know about the high versus low volume disease breakdown from these groups, but I think the data is pretty clear that for a poor prognostic subgroup of patients, that adding a novel hormonal therapy agent such as abiraterone or darolutamide to androgen deprivation therapy and docetaxel leads to significant overall survival benefit. The next topic I talked about was first-line metastatic castration-resistant prostate cancer, and that is adding PARP inhibition to abiraterone. In the MAGNITUDE trial, this was a biomarker-selected trial where patients received abiraterone or abiraterone with niraparib for first-line metastatic castration-resistant prostate cancer. In biomarker-negative patients, there was no benefit, but in biomarker-positive patients that had genes that were altered associated with homologous recombination deficiency, there was radiographic progression-free survival benefit to adding niraparib to abiraterone. In another study that looked at use of olaparib as a PARP inhibitor, this was the PROPEL trial, patients received first-line abiraterone or abiraterone with olaparib. This was an unselected study, meaning that patients were not mandated to have homologous recombination deficiency. It was an all-comer study. And in this study, there was a radiographic progression-free survival benefit to adding olaparib as well. I think the unanswered questions are, these studies are all not yet mature for survival, and we'll have to wait and see whether there's an overall survival benefit. Additionally, it's not clear that combination of PARP inhibitor and abiraterone is better than sequence of abiraterone followed by a PARP inhibitor or vice versa. Finally, I think the greatest unanswered question is the biologic mechanism of seeing benefit to adding a PARP inhibitor to abiraterone in a biomarker unselected population. We have yet to see regulatory approval, and I think we'll see further data in both of these studies. The third topic I talked about today was just an update on the data with lutetium PSMA-617. We've seen an overall survival benefit in the VISION trial when we take patient populations that have metastatic castration-resistant prostate cancer and have previously received both docetaxel and a novel hormonal therapy agent. In that VISION trial, lutetium PSMA-617 led to an overall survival benefit over other novel hormonal therapies. Now, the therapy trial showed that lutetium 617 PSMA showed PSA response benefit, radiographic progression-free survival benefit, quality of life and safety benefit over cabazitaxel, which is a very, very potent control arm. Now, it's not clear that this gives us definitive data on sequencing, but I think with all these benefits, even though at ASCO there was no overall survival benefit of lutetium PSMA-617 over cabazitaxel, the study was not powered to show overall survival benefit. So I think we must use our clinical judgment, and we see that there are other benefits that might point towards use of lutetium PSMA-617 prior to cabazitaxel. The other key thing that we learned from these studies, both the VISION and the therapy trial, is that PSMA PET uptake by SUV mean has prognostic and likely predictive potential for selecting patients who will respond well and have the best overall survival benefits and efficacy outcomes with receipt of lutetium PSMA-617. So thank you again for attending the 2022 Las Vegas ASCO Direct meeting, and again for listening to my summary of recent updates in prostate cancer. When you think about the newest data that's come out in prostate cancer, I think we have to ask, of all these things that I've discussed, what's actually changing clinical practice right now? And I think the thing that's most definitive for change in clinical practice as to what we do in the clinic when we see patients, that has to come down to the idea of triple combination therapy for patients with metastatic hormone-sensitive prostate cancer. Both the PEACE-1 study with adding abiraterone to androgen deprivation therapy and docetaxel, and also the ARASENS study with adding darolutamide to androgen deprivation therapy and docetaxel, should change standard of care for patients that have new metastatic hormone-sensitive prostate cancer. To be more specific, however, it's probably not for everyone. It's for patients that are fit for docetaxel and have de novo metastatic disease, or at least high volume disease characteristics. Not all the data's out yet, but we'll be seeing more data to come. But I do think that this is something we can start applying to our practice now, to when you give a patient with new metastatic hormone-sensitive prostate cancer, androgen deprivation therapy and docetaxel, that we should be further treatment intensifying with another novel hormonal therapy agent like abiraterone or darolutamide. And I think that we can start applying that in our practice as soon as possible. Thank you.